Hello, everyone. Thank you all so much for joining us for today's webinar on medical cannabis with Dr. Doug Benner, presented by Cecron. A few housekeeping announcements before we get started. All of you are on mute. If you want to ask a question, you're welcome to enter it into the online chat or Q&A and post following the presentation. We will be answering those questions and you can have those answers with Dr. Benner. I'd also like to say thank you on behalf of COEH and Cecron for joining us. COEH is the Center for Occupational and Environmental Health. We are here to help with workplace safety and workplace health needs. And we are approached by Cecron to do this joint webinar opportunity. And I'm going to hand it over to Nani, who's going to tell you a little bit about Cecron. So thank you so much again for joining us today.
Hello, everyone. Welcome to the presentation on therapeutic cannabis. Also, thank you to COEH for partnering with California El Camino Real Association of Occupational Health Nurses, otherwise known as Cecron. We are a regional professional association serving occupational health nurses with a focus on educational and legislative information related to occupational and environmental health. I would now like to introduce our speaker, Dr. Doug Benner. He's an independent consultant and serves as the Chief Medical Officer for EK Health, as well as a medical consultant for Marriott International Claims Operations. He was with Kaiser, which is how I know him. He was there for 35 years and created 31 occupational health clinics and the Employee Health Services Program for the Northern California region. Currently, he is enrolled in a 2-year Master's of Science program at the University of Maryland Graduate School of Pharmacy, a new program in medical cannabis, science, and therapeutics. This should be a very interesting webinar. I hope you enjoy it, and welcome, Dr. Benner.
Thank you very much, and I appreciate the opportunity. I know this is a very extraordinary time where we're all dealing with another major issue right now, but perhaps for an hour we'll have a little bit of a diversion. I'm going to talk about medical cannabis, and I just have a disclosure to make, which I have nothing to disclose. I have no financial interest in this content or in the cannabis industry. We're going to review the history of the medical use in humans, which goes back a long time, the legal history in the United States on the cannabis legislation and regulation. We're going to talk about the plant and what's in it, which is, I find, very interesting. Something about the pharmacology and the metabolism of the cannabis components. Going to discuss, if you're not familiar with the endocannabinoid system, I think you'll find that somewhat interesting. Then we're going to review what the scientific literature says about what are accepted and unaccepted currently uses for medical cannabis in humans, and then review some of the more common adverse effects. And then we'll leave some time for questions. I know this slide is not something you would want to see everything on it because it's very difficult to read, but it's an introduction really into the history of cannabis in humans. And it's a 6,000-year history. And on the right, you can see, we know at least 4,000 BC that in Central Asia, cannabis plant was being raised for its grain and its fiber. What we would now know in the United States is hemp was being grown around the world 6,000 years ago, especially in Asia, where it was used for textiles, rope, paper, and the oil. The oil could be used both for food as well as for lighting. Starting around 2737 BC, we have the first recorded use of cannabis in China for medical reasons. And we're going to review that all so that you can see that, then for 6,000 years, we had people using this substance and components from the plant. However, it's rarely rare, just very recently that it's been become totally illegal. And that in the United States happened in 1970. So again, just a little review of some of the timeline of human use of cannabis, starting with various emperors in China who were promoting its use a long time ago, back in starting 2900 BC. Then following, the product moved to Egypt, then was known to be used in India as far back as 1000 BC. And there's evidence it was also used during the Roman Empire. Other various cultures were using it throughout more modern times. And in fact, when the United States was settled, the Jamestown settlers brought the hemp seeds and hemp plants to North America for growing hemp for its fiber and oil content. Some of the earliest mentions of using cannabis in modern Western medicine go back to an English book on using it for depression by Oxford scholar Robert Burton back in 1621. You may find it interesting that some of our forefathers in the United States, because of hemp's value as a product for fiber, both George Washington and Thomas Jefferson on their plantations raised cannabis for the hemp fiber. Current Western medicine got its interest in cannabis in the Western world from Sir William Brooke O'Shaughnessy, who was a surgeon who worked with the East Indian Company in India and found a lot of evidence that's being used by a lot of practitioners in India. And he started giving presentations to Western medicine. One of the first recorded ones he did in 1839 was with the Medical and Physical Society of Calcutta, talking about its potential use for cannabis in cholera, rheumatism, tetanus, rabies, and infant seizures. Again, he brought back the information and some products of cannabis to England in 1840 when he returned, and started writing a lot about its potential use. In 1850, the United States actually added cannabis extracts to our US pharmacopoeia and mentioned that it's a valid prescription for treating neuralgia, tetanus, rabies, opioid addiction, gout, and seizures. There was also an article in Lancet in 1889 about using cannabis extracts for opium and chloral hydrate withdrawal. These are some very old pictures of old products that were used around that time, everything from corn plasters, but mostly the product was a cannabis extract. I want to talk a little bit about some of the legal activities that happened. In the United States, just historically, the predecessor to the FDA was in 1906, the Pure Food and Drug Administration Act, which was focusing at that time on labeling drugs. And so making sure that drugs, including cannabis, were properly labeled. They weren't really prohibiting, and there wasn't a lot of scientific research into their use, but just making sure that they were labeled. One of the first then drug acts beyond that was the Harrison Act of 1915, which was focusing on taxing the use of opioids, opium particularly. There was concerns about widespread use of opium dens in San Francisco, for example, other parts of the world. So the initial approach to illegalization was actually to tax the product. And there's a differential tax whether it was being used recreational or for medical purposes. But still, back even as 1918, the US pharmaceutical industry was growing quite a bit of cannabis for their medicinal products. In the 1930s is when we started hearing the word marijuana used instead of cannabis. And that came from after a lot of migration from Mexico, where the cannabis plant was referred to as marijuana. Here's some examples of some of the initial. At one time, Eli Lilly in Indiana was growing their own farm for cannabis and had at one time 40 different products that they were selling for a variety of reasons: antispasmodic, sedative, narcotic. And here are some samples of several products that Park Davis was another company from Michigan who was creating a lot of products for use of medical cannabis. Further, the interest in making the product illegal started with Henry Anslinger, who was the first commissioner of the Federal Bureau of Narcotics, and it's a position he held for many decades. He and others like William Randolph Hearst started campaigns against marijuana. He also was campaigning against alcohol. And by the late mid-30s, with aspirin and morphine now being more popular, there was less cannabis being used for treating pain. One of the political propaganda campaigns against cannabis started with the movie Reefer Madness, which was quite popular in 1937 and through the 40s, talking about the dangers of cannabis for teenagers. By 1937, the United States was continuing the tax approach and created the Marijuana Tax Act. It's not misspelled. That's actually how we spelled it, with an H instead of a J, back in 1937. However, even the American Medical Association at the time was against that law and felt that what we really should be doing is doing research on medical cannabis and not taxing it out of existence. Again, we had a lot of competition of what to do with the product. By 1942, cannabis extracts were removed from the US pharmacopoeia as an acceptable medical treatment. However, Mayor LaGuardia in New York had asked the New York Academy of Medicine to investigate marijuana. They had looked at what they found in the literature and found that it was not as dangerous as people thought. Also in about 1940 is when scientists first discovered the chemical compound we know today as CBD. They were able to create its structure. Further legalization in the 50s were focused on minimum penalties for possession of drugs. Different states were now starting to pass laws to restrict the use of many drugs, including marijuana. 1964, one of the really science on the cannabis components started really getting blooming around the world. Started in Israel, Hebrew University, where the structure of THC, and it was actually able to be synthesized by these scientists there and was first discovered, which then started a lot more research on what these components have and why had they been used for so long, and was there really any scientific evidence for their benefit. Many may not know that the United States has been growing marijuana for its use, which is generally for medical research. So all the research that goes on in the United States using cannabis products are grown in the United States at the University of Mississippi since 1968. There's some movement right now to allow more locations to grow cannabis for research, but right now the DEA has not approved any others at this time. The Bureau of Narcotics and Dangerous Drugs started in 1968. And by 1970, marijuana was then essentially banned because we created the Controlled Substance Act, which created, as you now know, are the different schedules, Schedule 1 through 5. Marijuana was placed in Schedule 1 with heroin, LSD, etc., because it was considered to have no current accepted medical use. Schedule 2, the main difference between Schedule 1 and Schedule 2 is Schedule 2 drugs are considered high potential for abuse and may lead to dependency, but there is current medical use. And so morphine, et cetera, were put in those groups. We now have 2 cannabinoid products for pharmaceutical use that are in Schedule 2, and we have one in Schedule 3, and now we have one in Schedule 5, which I'll talk about a little bit later. Continuing on the legal timeline for cannabis in the United States, after the schedules were developed in 1970, President Nixon declared his war on drugs. He commissioned the Schaefer Commission to look at marijuana and other issues of drug abuse, and his own commission did recommend decriminalizing marijuana in 1972. Also, President Jimmy Carter proposed to Congress that it decriminalized in 1977. We also saw starting in 1976 through 78, there were court cases which federal courts decided that certain patients should have the right to have access to cannabis. If they were not allowed to grow it, then the government should use its supplies that it had for medical research to give to people under Compassionate Act laws that existed at that time. And so by 1978, NIDA was providing cannabis to 7 patients for compassionate use. So now we're going to talk about how it became from illegal to legal in the United States. Interesting enough, one of the first things that happened was that THC, although it was Schedule 1, was allowed a synthetic form to be created and sold as Marinol. And it was approved in 1985 by the FDA, and then a liquid form was approved in 2016. It's been used and approved since then for nausea and vomiting associated with cancer chemotherapy in patients who fail to respond adequately to conventional antiemetic treatments. It's also been used and approved for anorexia associated with weight loss in patients with the AIDS syndrome. This is a chemical drawing of the chemical THC. And as you can see, it's identical to what Marinol is. There's no difference. It's just a synthetic creation of what's in the plant. Getting on now to medical marijuana, where we are today, San Francisco was one of the first areas to pass a Proposition P 1991, which was to call on the state of California and the California Medical Association to get hemp medical preparations available to treat various medical conditions for Californians. California followed in 1996 and was the first state to pass medical marijuana law, legalizing its use. It did require a physician recommendation. I use recommendation because it is illegal still, so physicians still cannot write prescriptions for marijuana, but they can write recommendations in medical marijuana states. And there were a list of medical conditions that it was considered to be acceptable for. A couple years later, you can start seeing Alaska, DC, Oregon, Washington started passing laws allowing medical marijuana. And so the yellow balls going through time are the various states legalizing medical use of marijuana and cannabis products. The states listed in white are the beginning of recreational, or it's often referred to as adult use marijuana. That started in 2012 in Colorado and Washington. And on this slide, I can show you where this has continued over time. And now Illinois is the latest state this year to legalize adult recreational use of cannabis in the United States. On this map, we look at from the National Conference of State Legislatures as of last summer, where we are in the United States. As you can see, the very, very dark green states have both adult recreational use as well as medical use, and the medium green states have medical cannabis programs. The light green states have allowed the low THC CBD only products to be sold. And then the other 4 states haven't made any decisions at this time. Interesting, I find just historically, the United States itself owns the patent for using cannabinoids as antioxidants and neuroprotectants. Haven't done anything with that yet, but it's there to be used for developing other products in the near future. I want to talk a little bit about what's in the plant itself. These are just some of the common names used in public discourse about talking about the marijuana plant. We hear a lot of conversation about hemp and versus marijuana. Hemp is generally referred to as, it's the same plant, it's all cannabis sativa, but the hemp version is grown usually outdoors, and it's grown to have very low THC content. In the United States Farm Bill we had a couple years ago passed defined it as having less than 0.3% THC in it. It is grown still like it was 6,000 years ago for the CBD oil, the hemp, which is hemp oil. It's used for fiber. It's used for a lot of different products. Where the marijuana, which we refer to, is the cannabis plant that is grown a variety of ways so that it has high levels of THC. In nature, when people are growing this, we have a whole range of hybrids that contain various amounts of both CBD and THC. But most plants will have both, just different quantities. Interesting, the cannabis, the marijuana grown, say 30 years ago, had an average THC content of around 2-3%. Through creative botany, we now have plants that have up to 20% THC in them, which is used now in the medical marijuana manufacturing industry. Just a little bit why hemp was used so long. It's very valuable. There's many components of the plant. You know, you've probably seen shirts and fibers and blankets and all kinds of things, rope made from the hemp fiber. Probably see less of the hemp food products, although they've been around for a long time. But we are now seeing a lot of CBD cosmetics, soaps, creams, etc., that aren't just for medicinal use, but are used for so-called wellness. A little bit about now the strains. So with creating different hybrids, and this is a type of a slide, I just want to get a disclosure, that you would see in a medical cannabis or recreational cannabis dispensary. These are not necessarily scientific terms. I'm just showing you to say that there's this range of hybrids. The sativa hybrid strains tend to have more CBD and less THC. The indica have much more THC. And then we have now over 1,000 different hybrids. And I've just listed here a few with some of these very unusual names. And if you went to a dispensary, they would tell you that this different hybrid has what percent of CBD versus THC, as well as we're going to learn about other cannabinoids that are in them, as well as other chemical substances like terpenes and flavonoids. And they all have different combinations of those chemicals. This is what actually THC and CBD look like. I showed you THC earlier, but I think you might find interesting that if you look at this ring bind here, the only difference between CBD and THC is a single open ring. So it's interesting that this plant creates these two chemicals as well as 600 chemicals. And they're very similar, but CBD is non-psychoactive, does not give a high, whereas THC does, and the only difference is one closed ring. The other thing to point out, we'll talk about a little later, is this hydrocarbon tail, which is on both of them. And this, as well as their other structure, makes these components lipophilic, which means they love fat, and that's very important on how they're absorbed, as well as how they quickly enter the brain-blood barrier. Another typical slide you might see in a cannabis dispensary, but it does point out that we have a group of components that are related to the THC, which are very psychoactive. Then we have other components of the plant which are more in the family of CBD, and they are non-psychoactive, but do have medicinal theoretical purposes. The other thing I want to now introduce is what's called the entourage effect. So as new pharmaceutical products are being developed, they're learning that it actually, if you think of a symphony orchestra, you may have the sound of one instrument, but when you put a whole orchestra together, you get a different sound and a more robust sound and a different effect. That's also what we're finding with the cannabinoids, is that besides, there's over 100 different cannabinoids besides CBD and THC in the product, and many of them have activities that affect humans. We also have over 100 terpenes, which are what give the plant, and many other plants, their color, their smell, their aroma, and their taste. And then flavonoids, which are also related to color, flavor, and taste. But they also have physiological reactions in humans as well as other animals. Here's some example of the terpenes. This is from CBD oil, but these are also found in the THC components as well. they're named sometimes for what they smell like smell like lemon, smell like pine, smell like eucalyptus. And these all have a variety of physiological reactions in humans. And so we're starting to see now experiments with looking at how you put different components together with different ratios of CBD and THC to get different physiological effects. I want to talk a little bit about metabolism of THC because it has a lot of bearing on how different humans react to the drug, how long the drug lasts in the human body, and how long it has an effect. In the top we have, if you inhale it, it goes instantly into the body through the lungs, to the heart, and throughout the body, the brain, and everywhere else. It'll eventually get to the liver and other organs where it is then further metabolized. At the bottom, we see if you ingest THC, goes through the gut, goes to the liver, and there, any drug that gets into the liver goes through what's called first pass effect, where the various enzymes metabolize it into other components. And that has a lot to effect on what we see, depending on how the person consumes the material. In the middle, we see what happens with THC in the liver. It's turned into a hydroxy form, and this, although the hydroxy forms are very low in quantity, they're much more powerful from a psychoactive perspective than the precursor THC. Further metabolism forms a carboxy THC, which is what's excreted in the stool and in the urine. When we do urine testing for marijuana, we're actually measuring the carboxy form of THC, which can persist for quite some time in humans. It is non-psychoactive though. So what we're testing is a product or component that has no really much physiological reaction, but it is what we can measure. What's interesting about and what makes a lot of challenges to how people are trying to use cannabis products for medical use is the quite extensive fluctuation in bioavailability. On the left, the only difference here is two different people inhaling the same dose, yet the THC concentration was 3 times higher in one individual who was more efficient in how they inhaled the product. Same thing, what happens with the ingested form, because of the first pass effect going through the liver, everyone's liver is different, everyone's conditions and status of enzymes are different. Also, we're going to talk a little bit about later how other medications that individuals are taking or supplements and diet affect the metabolism in the liver. So you can get quite a bit of variability on how much drug is available. However, you will always get more drug inhaling than you would through ingestion. To put it in perspective, when THC is inhaled, within seconds, the level goes up pretty extensively, but it also drops very fast. However, the other metabolites I mentioned, the hydroxy and the carboxy versions do continue. And even though the hydroxy is very low, it's very powerful and it can give a lot of euphoria. The carboxy version, which is what we test, as you see, can persist in some individuals up to a week, although for most people within 24 hours, it's out of the system. Again, when it's ingested, we see that the carboxy goes way up real fast, and then it persists for a lot longer. However, the other components stay low, but the THC, when it's in the ingested and it's in the hydroxy form, is very, very powerful. So even though we have a low amount, it has a high effect. And so now we're listening to two different things. So when people take cannabinoids orally, they have a delayed onset, as well as they create a product, a metabolite, that is actually much stronger than what they ingested. So therefore, they can have a lot longer and a lot higher therapeutic effect, or if they're using it recreational, a lot higher and longer period of inebriation. Just to summarize the differences, when you inhale, you lose about 50% of the chemical from just burning it, but it quickly goes in. It's really an immediate onset. It peaks within 10 minutes, and the duration of effect can be a couple hours to 4 hours. However, when you ingest it, the absorption and the bypass through the liver, you have an onset sometimes as late as an hour and a half, and it can peak variability on individuals between 1 and 6 hours and have the effects last for 48 hours. So this is one-handed. The oral is a very dangerous thing because people who are experimenting, when they take an edible, they feel nothing because they think, well, they're supposed to feel something shortly. They don't, so they take more, and they get toxic fairly quickly because they consume more than they can handle. However, for therapeutic use, for people with chronic pain, for example, cancer pain, etc., using oral preparations are good because you get a lot longer duration of effect of the drug. We have other modes of administration. We've talked about inhalation and oral, which are in the middle here, but sublingual is very popular. It's also very quick onset and does last a long time. Intranasal is used with some of the newest medical preparations. It's very quick. Within seconds, you get an effect. Edibles, we mentioned, take a long time. There are topicals. There's a variety of differences of how effective topicals are. CBD seems to be more effective going through the skin than THC. But both have been used. And then we have suppositories that are used, which also have fairly quick, rapid onset. Now I want to introduce the endocannabinoid system, which is somewhat interesting if you're not familiar with it. When scientists were trying to figure out why these chemicals do what they do in the humans, they did a lot of explorations, and they found that, you know, we have in humans and in all mammals an endocannabinoid system. Now, it's interesting. We found these receptors back in 1988, and they were further defined in 1990. And then by later in 1990, scientists were able to map the brain and find out where all these receptors were. Further study, they found that this system, which is now called the endocannabinoid system, and it was given the cannabinoid name because this is exactly where the THC interacts in humans with these receptors in the brain and the nervous system and in other organ systems of the body. And as this system has been studied over the last 30 years, we've found that it is actually the signal modulating system for much of our activities of human life. Everything from inflammation, anxiety, how our brain works, seizures, protecting our neural system, protecting our heart, fighting cancer cells, you know, fighting nausea. All types of things are modulated by this endocannabinoid system throughout the body. The main way it works is, although CBD, for example, we'll talk a bit later, has a lot of reaction with other enzyme reactions and interfering with other components in the body. The THC primarily works in the neural system, and in the brain and the spinal cord, it works at the synaptic junction. We have the cannabinoid system that we have in our bodies has internal endocannabinoids, and they are also fat soluble. As we showed, they also have the hydrocarbon tail, and so they exist at the postsynaptic junction of a neuron. And they're there, and when it's time for a signal, a variety of things signal them to do something, they're released, they cross the juncture, and they react with one of the G protein receptors we mentioned earlier. It's also the same receptor that THC connects with. And when they do that, I'll show you the next slide, what happens. So what happens when they connect, whether it's an endocannabinoid or it's a THC, it hits one of these CB1 receptors, and what that does, it stops the release of the neurotransmitter. So the neurotransmitter that was coming down to cross the junction actually gets blocked, and that creates some of the effect. So for example, if this was a signal for pain and these two, either THC or the endocannabinoid acts, it would block the signal or some of the signal from coming down, so it modulates it. It could also be a signal that someone has eaten enough and they're full and therefore they have no appetite. Yet that appetite signal could be blocked so that then somebody feels like they could eat. And that's why it's helpful for people with AIDS. We have two major THC receptors in the body, CB1 and CB2. CB1 are primarily in the brain and the spinal cord, and the CB2 are in the GI tract and the immune system throughout the body. Showing, which is interesting, so this is one of the common internal cannabinoids that is normally there working nonstop 24 hours a day, doing this modulation of most of the biostasis systems in our body. And as you see, it's structurally very similar to the drug THC. Again, they both have the same hydrocarbon tail, which makes them both, our internal ones are also lipophilic, as well as the THC. Why that's different is that most drugs are designed to be water-based, so they'll dissolve in water, like sugar dissolves in water. That way so it creates a lot of interesting pharmacological challenges trying to create drugs with the products that are fat-based. Again, how the CB receptors affect body, they control things like motor activity, thinking, motor coordination, appetite, short-term memory, pain perception, and immune cells. Where CB2 are in the GI tract, eye, tumor, they're also involved with bone development, muscle development, and the endocrine system, as I mentioned, and the immunology system. For those of you who maybe heard about the blood-borne barrier, but maybe have forgotten what it is, normal blood vessels have pores and water-based products leak in and out very easily. However, in the brain, the vessels are sealed, there's no pores, and you have the lipid barrier. So a lot of liquid, water-based drugs need transporters to get them across the barrier. However, lipid-soluble substances like the cannabinoids, whether they're the internal or the external ones, easily go through the brain-blood barrier. So when someone takes in a hit or inhales or takes some way of inhaling cannabinoids, it immediately goes into the brain right away. And the brain, depending on what part of the brain is affected or has these receptors, has a lot to do with the reactions. So as you can see, the amygdala controls our emotion, fear, and anxiety, whereas we have other parts that are, controlling appetite, motor control, memory, etc. Here's something from the DEA Museum. And what I really want to point out, well, because we're going to mention it later, this is just where these CB1 receptors are found in the brain. What we don't see, you see all these different areas lit up. There's the cerebellum, the cortex. The brainstem is down here, and it does not light up. There's very little receptors for the cannabinoids in the brainstem. While this is important, is the brainstem controls respiration and breathing. So when someone dies, for example, of an opioid overdose, what they're dying from is they stop breathing. One dies from overdose of THC. They might die if they have a car accident, but they may feel terrible, but so far no one's ever been recorded of dying from an overdose of marijuana because they don't stop breathing. They may feel terrible, they may feel like they're gonna die, but they don't. So again, just a little summary how it works. And one of the problems when someone inhales marijuana, they're overwhelming the system that exists. And so sometimes that can give you a therapeutic effect if you're trying to stop pain or you're trying to increase appetite. However, it can also cause a lot of significant side effects by overloading a system that is there for another purpose. THC has wide-ranging effects, but it slows down reaction time. It disrupts our ability to remember, especially short-term memory. It can, although in low doses, it can help anxiety. In high doses, it makes people anxious. It can affect judgment. It does affect the part that makes people feel good. Therefore, that's how people get the high or the feeling of inebriation. It can help dim pain signals, dim vomiting and nausea signals, as well as dim appetite suppression signals, as we mentioned. CBD, on the other hand, is non-psychoactive, but it is, in high doses, can be sedating. We know much less about its pharmacology and metabolism and the way it's eliminated. It has a few other type of receptors, but it also has a lot of actions working with enzymes and other chemical reactions, such as serotonin receptors. So we're learning more and more about why it does what it does, but it does seem to have some help in relieving pain, especially if the pain is caused by inflammation. This also has an effect on the neuroprotective actions of the brain. And that's why it's been used now in epilepsy and some movement disorders like Huntington chorea. I want to talk a little bit now about some of the other medical cannabis products that have been developed. Charlotte's Web, some of you may have heard the term, but it was a nickname for a product of CBD in Colorado, where a mother had found she had a child with one of the severe catastrophic seizure disorders, where children can have 400 to 500 seizures a day and will eventually become mentally retarded. Dravet syndrome is one, and Lennox-Gastaut is another. And so there was a fast push to get a product out that had been developed in Britain for treating childhood seizures, which is CBD, cannabidiol, which is from an extract of the actual plant. So the FDA approved growing the cannabis plant for this product, as well as allowing it to be sold in the United States. As you can see, it's very expensive. We have other products that have been developed. I already mentioned Marinol and Syndros, which are synthetic THC. We also have Sesamet, which is a synthetic cannabinoid, a similar structure to THC, and it's also used for nausea and vomiting. Epidiolex, I mentioned, in 25 countries, the same company that makes Epidiolex has a product that's 1-to-1 ratio of THC, plus it has other components from the plant. And it's been approved in 25 countries to treat spasticity of multiple sclerosis. What's interesting about this product is because it's been studied in so many other countries, we now have a lot of scientific literature on using this kind of a ratio to treat other medical conditions, although they're not approved for it yet. And it's not approved in the United States at this time, although I think it's under FDA review. So what is someone going to find in a cannabis store? We're going to find a lot of different things, lots of flowers. As I mentioned, there's 1,000 varieties, and people sell different varieties thinking that they have, or feeling they have different evaluations. We have vape pens, we have tinctures now. We had tinctures years ago, now we have tinctures now. And we have a lot of food products as well as cosmetics and creams and lotions and potions. Different ways that people inhale. They use the cigarette, they use the bongs, they do dry powder, but we're now starting to see a lot of scientific type more medication. So we're now having inhalers that deliver an exact dose with each inhaling. And this is similar kind of devices used to treat, like a lot of people use albuterol and other asthma medications, same type of device and chemical. Lots of food products that you've probably heard of. We also now have other transmucosal issues. We have membranes that are dissolved in the mouth, and tinctures and oral sprays and lozenges. And just a reminder that the underneath the tongue is very vascular. And so just like nitroglycerin is used that way, a lot of these drugs can be used this way, and they get into the blood system right away. So I just want to quickly review what we now know is the current state of medical evidence for using marijuana products. The National Academy of Press has done over the years several studies. The most recent one is from 2017. They looked at 24,000 abstracts in the world's literature, and that had been published since 1999 on cannabis, and looked at in more depth over almost 11,000 of those. And their summary of recommendation of what is currently known in the medical literature is that there's conclusive evidence that cannabis is effective for chronic pain, which is the most common use in medical marijuana settings. Substantial evidence it's effective in chemotherapy, induced nausea and vomiting, and spasticity and multiple sclerosis. And moderate evidence it helps sleep, especially with the individual with sleep apnea and chronic pain and other pain syndromes. Less effective evidence that it's helpful in appetite and weight loss and HIV, although it's approved for that. Tourette syndrome PSD, and also social anxiety. There's some evidence that it is not effective for dementia, glaucoma, and depression. It's interesting. A lot of people had used it for glaucoma, but scientifically, we don't have a lot of good evidence that it works. Don't have any evidence to support or refute that it's useful in these things, such as cancer, weight loss, irritable bowel syndrome, schizophrenia, etc. It is fairly clear that it can affect, especially chronic use and acute use. It can affect short-term memory and attention. One of the concerns is that long-term use has been associated with some testicular tumors. However, there's no statistical association with cannabis smoking and lung cancer or head and neck cancer. It will make individuals who have respiratory problems worse when they smoke, which doesn't seem surprising. And if you stop using it chronically, your respiratory symptoms will improve. And there's limited evidence that it's associated with COPD. For women are recommended not to use the product while pregnant because it is associated with lower birth rates, increased complications, and more neonatal intensive care unit admissions. There is an association of schizophrenia and psychosis, especially with higher uses, people who use it chronically, as well as youth, young children. Recommended do not experiment with the products because their developing brain give them an increased risk of developing schizophrenia and other psychoses. There is a statistical association with cannabis and the development of other substance abuse, although we don't have strong literature to support causation. So their debate, is it a gateway drug or not gateway drug? I don't have a strong opinion. A lot of people who use one drug use another, including alcohol and tobacco. I want to get into some of the side effects. First, we'll talk about addiction. This is just to put in proportion the amount of people addicted with both alcohol and drugs. So these are alcohol and drugs, and then this is drugs and alcohol in this area. Marijuana is addicting, 9% lifetime addiction rate from NIDA, and it increases the more people use and if they start early. So again, teenagers, besides the schizophrenia risk, will also have a higher risk of becoming addicted if they start young. And again, people who use it chronically over years, 20, 30 years, many of them become addicted long-term. But in comparison, cannabis is, lifetime dependency risk is 9%. Nicotine is still our most addictive drug that humans regularly use. Heroin, cocaine, and alcohol are somewhat less. One of the risk factors for adverse thing is car accidents. We hear a lot about. It's interesting. This is from Time Magazine. As you can see, over the last 15 years, they've put out articles saying that marijuana reduces fatal accidents or increases fatal accidents. Very, very confusing. So what does the science show? So I looked at the National Highway and Traffic Safety Administration to see what their data shows. And again, obviously marijuana slows reaction time, decreases attention, has individuals having trouble with staying in the correct part of the lane. However, as composed to alcohol, alcohol users actually leave lanes. People with marijuana just have wobbling but don't tend to leave the lane. One thing that may help them is that people who smoke marijuana tend to have reduced speeds. They stay further distant from somebody else, as composed to alcohol, which have higher speeds, greater variability in speeds, and a lot of speeding over the limit. One of the reasons why I think THC has an effect in the brain, this is something we saw earlier. You can see it quickly goes up and then tapers off. That's the THC level after inhalation. However, what's concerning is in the green, we have effect on performance as well as the feeling of being high. And as you can see, because of the metabolites we mentioned earlier, even though the drug goes up and goes down and maybe is not going to be detected, it is having a long-term effect on the individual. As opposed to alcohol, which has a very steady state, it goes up quickly, and then it slowly comes down. When someone has a breath alcohol level, these levels are exactly associated with, one, we can determine how long ago they took and how much they maybe had. Plus, it also has a direct impact on their impairment, the different alcohol levels. Different states have different laws on driving impaired. Colorado is the only one that actually has set a target limit for how much someone could have in their system. Again, I just still want to point out alcohol is still the problem. Even though there is increased risk with illegal drugs, including marijuana, when you adjust for age, gender, et cetera, there is no significant increase in the crash risk associated with drugs. Alcohol is a totally different story. Here's THC and illegal drugs. If you adjust for those things I mentioned, it goes away. However, alcohol is directly related to the quantity of alcohol in someone's system. If someone's up to 0.2, there are 23 times greater risk of having a crash than without. I also want to cover a little bit about the vaping issue that became very prevalent in 2019. In December, we had a lot of hospitalizations. We've had about 60 deaths occurred mostly in young people. Here, what you see is the upswing and then the down. Right now, there's actually very little of it being seen and reported, and that probably has a lot to do with people figuring out what was causing it and making corrective action. Again, there were a few states that had more than others. How it works, the oil and other heavy metals from the vaping product get in the alveoli of the lung, causes damage, in some individuals causes a severe fibrous reaction that can make them quite ill. CDC recommends do not using THC containing e-cigarettes or vaping products, and particularly from informal sources. It's now felt that vitamin E acetate was the cause of most of the problem. It's not something that's used in the commercial products. It is something that was added by informal sources, people refilling products that they'd bought at a dispensary, and then they were able to refill it, and they mixed the vitamin E in to dilute the extracts that they were using. Again, as we're learning, there are certain formulations that we will figure out how to make so that these inhalation products can be used safely. Again, this is just showing that there is no lethal dose for THC as opposed to alcohol. This is comparing the lethal dose with the average amount of intake. So you can see alcohol is still one of the highest risk drugs that people consume, as well as heroin, cocaine, and actually cigarettes. Another description of that. I want to talk quickly about drug interactions because that has a lot of effect on what we do. Just a quick review, we have both drug to drug, drug to food, and drug to disease. Drug to food is important because of the lipophilic component of the cannabinoids, and so therefore if someone eats them with fats, they will absorb more. In the liver, we have both inhibition and induction. Inhibition of an enzyme decreases its rate of metabolism, therefore the other drug goes up in concentration, which can be quite dangerous. Or we can also have an enzyme have the opposite effect, where it's an induction. It increases the rate of metabolism, which then would decrease that drug concentration. Not to get into all the different enzymes, but basically the thing to know here is that one of the enzymes that is both inhibited by THC and CBD metabolizes approximately 65% of the medications used in today's medicine. Some of them have much more impact than others, but it's very dangerous for people taking other medicines not to know what to do about using these cannabinoid products. For CBD in particular, it uses up a lot of this one enzyme, CYP3A4, so therefore it's recommended it not be taken within several hours of some of these other medications. Some should not be taken at all. For example, anticoagulants like warfarin and Plavix, some antidepressants, these are ones I've listed that have significant interaction with the enzymes. And so these top ones, these drugs can be increased in their concentration, which can be very dangerous on somebody on warfarin, for example. Also, the reverse can happen. And so some drugs can actually increase the concentration of THC and CBD, such as rifampin and Multac, which is used in atrial fib. We're getting a lot of research. We need more. This shows the uptake in research in the last 30 years. Right now, there are more, I've heard more articles in PubMed on cannabis research than any other substance. Just a few reminders. It's been used for a long time for food, fiber, inebriation, and medicine. Its illegal status is rather recent in US history, but it does hamper our research in this country. International scientists have led the world in studying its effect, and now we've identified over 500-600 chemicals that are in the plant. Little trivia is that the THC is greater in the female flowers. This endocannabinoid system has existed since mankind. It's a signaling system that helps regulate many aspects of homeostasis. Although individual cannabinoids have significant effects, sometimes when they work together, they have the entourage effect, which can give a stronger impact. We have over 1,000 different chemivars, which are different varieties that have different chemical components. I'm not going to get into treatment specifically with dosing, but the recommendation to go low, go slow. There is some biphasic effect, which, for example, for pain, low doses may help pain, whereas in anxiety, where higher doses can actually make them worse, which is interesting. Currently, we have more myth than we do have science, and we have lots of challenges in figuring out how to administer and dose these products, but we need a lot more scientific medical expert than someone would get from a bud tender in a dispensary, whereas most people using medical cannabis, that's where they get their information. It's not a proven gateway drug, although it is addicting. It does not kill people. However, if you have a car accident under influence, you can kill yourself and somebody else. Again, I mentioned the issue on edibles, and I'm available for any questions.
For that great presentation. My name's Julia Buss, and on behalf of CCRON, I can ask a few questions that have come in, and if anyone has any additional questions, they can enter them in the Q&A. Before we go ahead, though, I just wanted to say to everyone who's listening, if you're a nurse and you want a continuing education credit, please fill out the evaluation and we'll send you a 1-hour CE credit. And anyone else, we can send you a participation certificate, but no CE credit. So that having said, one question that came in is about the effects on cardiovascular health. And is there any advice for people with existing heart disease?
Yes, American College of Cardiology has been putting out a few papers on that. It can increase heart rate, and there's concern with individuals with certain, like congestive heart failure or arrhythmias. They have to be very careful how it affects their heart rhythm and their muscle contraction. So it's something that individuals with cardiovascular disease need to be very careful.
Oh, yes, that's good. A few people are asking if they can get a copy. Will we be able to make available a PDF? Are you willing to share that with those who listened to the webinar?
I'm going to look at how to do it. Because I have a lot of photos and graphics and things, it doesn't copy well. So I'm going to look at how I can get the content into sort of a note or text format and share with people. I'll work on that and get it to you.
So if we can, we definitely will. And
for example, I tried emailing it and you can't email it. It's as it is because of all the graphics and things that look pretty or do take up space. But I'll work on getting you something.
Okay, thank you. And again, just to say about the CE credit, you'll all get the opportunity to complete an evaluation either at the end of this webinar, or you'll get an email tomorrow, a follow-up email. And then if you fill out the eval, we can send nurses CE credit for 1 hour.
You gave us a really good history at the beginning of, the sort of long process from cannabis being on the pharmacopoeia to becoming illegal. And somebody had asked a question about what made marijuana illegal. And so given that you gave us that big history, I just wondered, is there maybe like one big thing you think that drove it to become a Schedule I drug? Or?
Well, history is interesting. A lot of people interpret it. As I'm studying it, I did a whole semester on the histories to get going with the master's program. I'd say there's two things. There were interests in growing hemp for fiber, and as paper products started coming out, there was some of the logging industry was interested in not having that hemp competition for fiber when they could produce paper from trees. The other thing is there was a fair amount of racism and political stratification that went on. The term marijuana actually was a derogatory term, which was targeted towards, after the Spanish-American War, we had more people coming in from Mexico, where it had been used for a long term for not just recreational, but had been used for medicinal purposes. And so then, just like there were also concerns about certain city populations, I'll just leave it at that, who were using so-called the reefer madness, using marijuana recreational. So when Anslinger came in and he was campaigning against alcohol for recreational use, he was campaigning against all drugs for recreational use, and then he targeted marijuana. And he had a lot of support politically, even though from the beginning, whether it was the AMA, the Lancet, professional societies, presidential commissions, they all were opposed to making it totally illegal, cannabis, because it had been used so long as an extract, even though it was not real scientific, but many physicians had used it for centuries. So, and even to this day, there's legislation in federal court, judges making proclamations that it should be decriminalized. And it eventually will, because if it was Schedule II, for example, like codeine or morphine, we could still control it, but we also could then study it easier. Right now, the process to do medical research using cannabis is very extensive. You got to go through 4 federal agencies, besides FDA, to justify your study. You have to get NIDA approval, you have to get the Justice Department's approval, and you have to get the DEA's approval, even to get the material to do the research. Other countries like Israel, I think it's Israel, or in Italy, the army grows cannabis for medical research. Italy's doing a lot of research. I think in Israel, some of the research centers grow their own. I mean, we still grow marijuana in the United States, University of Mississippi, but they can only grow so many varieties, right? And so when you're starting to look at all these other chemical components in the plant, you need source material that has variety of proportions of both THC, CBD, and other cannabinoids, and the terpenes, which also have physiological actions in humans.
We have a few more questions, and so we'll keep going for another 10 minutes, maybe till about 1:10. So if anybody is able to keep listening, we'll make our way through the questions. There are several questions about mental health, and one is there any research on relationship between cannabis use and mental health disorders with respect to violence?
Well, in regard, it is being used by some practitioners for post-traumatic stress disorder, especially in people coming back from military experiences. And some of those individuals have violent tendencies. Not everyone with post-traumatic stress disorder does, but some do. And so in that regard, some people are finding it helpful in helping relieve some of the symptoms of post-traumatic stress disorder. It's also used in low doses to help some people with anxiety. CBD particularly has been shown to be effective in social anxiety. So individuals who are, for example, afraid to give a speech in public, have found that low-dose CBD can help them. However, because its impact and how its causative relationship with schizophrenia and a few other psychoses, there's a lot of research going on and why is that happening, and exactly how does CBD prevent seizures in these children. So we're going to see more neurological research on these components. But what we do know is that, youth who start too early with too much have a high risk of getting schizophrenia, and long-term users of high quantity for daily use have after 20, 30 years, have a definitely increased risk in developing schizophrenia and other psychoses. We don't know why, but it's there. And sometimes when you have a problem, that actually can lead you to a solution. And again, there's so much to know about this plant and 600 different components in it. And we do know, for example, although I mentioned, there's one of the cannabinoids like THC can help stimulate appetite. There's a cousin of THC that actually decreases appetite. And so, for example, there have been, we have components that can help people eat who can't eat. And then you have a similar component, if you could isolate it and just give them that, will actually take away their appetite. So again, there's a lot of chemicals in this plant, and we know that they interact in the humans in a variety of different ways, which we understand some of it, but there's a lot we don't understand. So there's going to see a lot more research in that area right now.
We couldn't really say now that cannabis caused schizophrenia, but you could say that if you that it could exacerbate or trigger or something like that.
Well, it actually seems, there's thought it can trigger it. Whether the person was a high risk for that, I don't know. But yes, there's definitely a very strong association, that it's so strong that some would argue it's causative.
Okay.
But probably a lot we don't know about schizophrenia as well.
Somebody else had asked another question about paranoia from THC. Does CBD have the same effect as to cause paranoia?
No. CBD is not psychoactive. It can be sedating in high quantities, but it's not psychoactive. In fact, in higher doses, it can also bind loosely to some of the CB1 receptors in the brain. And when it does that, it can attenuate the psychoactivity of the THC. So it can actually help reduce. So some people would recommend, if someone got overdosed on THC, one thing that they could do is to take some CBD, because that could help decrease paranoia and euphoria.
There's an interesting comment from somebody saying about the symptoms from the EVALI vaping are very similar to COVID-19. And so it's important for those who do vape, who think they might have COVID-19, to tell their doctor that they vape, which is an interesting comment. Somebody else asked about the potency of THC increasing nearly tenfold over the past 30 years. Is that correct?
Yes, it was 2 to 3% and now up to 20 to 25% concentration. And that's through creative hybrid botany of, I'm not a plant expert, but basically people, doing grafting and farming and working on ways to, and then also with indoor, I didn't want to get in too much into the growing aspect, but there's a whole science on that. And, whether the plants grows outside, it has a lot less THC. And lighting has a lot to affect. People do things to trick the plant of the season, because normally left to its own, it's a short, light plant, so it comes into flower, like in the fall when the days are getting shorter, if it's in that nature. But when you grow things indoors, you can do a lot of other things to change how the plant generates the drugs. So it's both manipulation and growing as well as hybrids, as I understand it. But I'm not an expert on plants.
And now we're at 10 past, so I'll just ask you one more question. And that is somebody asking about workers' compensation. Well, sort of a series of questions asking, you know, if it's legal now in workers' compensation. And
Okay. Yeah, I do have slides on that, but because of the time, I decided what to eliminate. But I'll just basically say this, is that it's strongly recommended by everyone that THC containing products should not be used by anyone who has a safety sensitive physician. And again, I think we showed that that effect can last for some time. Under federal law, under the transportation, and also, you know, if you work in railroads or cross-country trucks, or you work at a nuclear facility, you're not allowed to have you're not allowed to use it ever. You know, and if you do, you'll be taken out of work. So that's the situation. Workers' compensation, it's interesting. There are several states, including mine and Nevada, recently passed a law that said you cannot do pre-test. You cannot test employees pre-testing for THC. So you cannot use it for discrimination in hiring, that somebody's used it. Now, I think an exception would be a safety-sensitive physician, and perhaps public officers, that would be an exception. There are 6 states now that have had judicial decisions to say that medical marijuana must be covered by workers' compensation, but only 6. And so in most jurisdictions in the United States, it's not mandatory to be covered by workers' compensation, basically because it's illegal under federal law. Also, being illegal under federal law, it's very difficult to pay for it. You can't use the normal federal banking system to pay anyone for it. You could reimburse a patient, but you couldn't reimburse a provider or a dispensary or a source. Although we do have now, you know, we have now these pharmaceutical grade products. We have 4 now in the United States that are approved. So those can be used by anyone and paid for by anyone. And workers' compensation would have to pay for those because they're FDA approved.
well, thank you.
Does that answer the question?
Yeah, that was very helpful, and I appreciate your taking extra time to answer these questions. And actually, we have so many that it makes me feel like we should do another follow-up webinar at some point because there's such interest. I don't know. The only other thing I was going to say is that we will make the recording of this webinar available on the CCRON website, which is ccron.nursingnetwork.com. So if anyone wanted to watch it again, they would be able to, or share it with any colleagues they think may be interested. So thank you very much for spending your time and sharing your expert knowledge with us today. It was super helpful and really interesting. Very much.
And if you have any other pressing questions, you could email them to me and I'd be glad to respond to you in writing.
Okay, thank you very much.
Thank you.
So much, Dr. Benner. Appreciate it.
Thank you all so much. And on behalf of the Center for Occupational and Environmental Health and our continuing education program, a special thank you to everyone who joined us for today's webinar, to Dr. Benner for sharing his expertise with us, and also to CCRON for coordinating this event. Thank you all so much.